in this video, we're going to be talking about neutrophils, but more importantly, we're also going to be talking about neutrophil arrival and their function in regards to acute inflammation. By the end of this video, you will completely understand what neutrophils are, their origin, life cycle, their function in acute inflammation, also their relevance. We're also going to talk about neutrophil recruitment in acute inflammation, which includes margination, rolling, adhesion, transmigration, and chemotaxis, phagocytosis, destruction, and resolution. Then at the end, we'll throw in some USMLE practice questions to help solidify your knowledge for the long term. Be sure to check out thehealingpowerofnature.com and also our Patreon for some of the best materials on the market and also support this channel. Neutrophils are the most abundant type of white blood cell and serve as the first line of defense in acute inflammation. They are part of the innate immune system and specialize in phagocytosing and destroying invading pathogens, particularly bacteria and fungi. Their rapid response to infection and tissue damage makes them essential for host defense. So some key characteristics of neutrophils. First, they are in the granulocyte classification, which means neutrophils belong to the granulocyte family, along with eosinophils and basophils. They contain primary and secondary granules, which store enzymes essential for microbial killing. Their life cycle, they are produced in the bone marrow under the influence of granulocyte colony stimulating factor, or GCSF, and circulate in the blood for about 8 hours before migrating to tissues. They survive in tissues for about 1 to 2 days before undergoing apoptosis and being cleared by macrophages. So morphology, so they have segmented nucleus, which allows flexibility to pass through capillaries. They also have a pale cytoplasm with granules containing enzymes like myeloperoxidase and lysozymes. They're the first responders to infection and injury via the following steps. We're going to talk more about this, but just to give a brief overview, they marginate, roll, adhese, and transmigrate. The chemicals they follow are IL-8, C5a, and LTB4. Through phagocytosis, they engulf pathogens enhanced by opsonins like IgG and C3b. The killing of microbes happens during oxygen-dependent and also oxygen-independent. For oxygen-dependent mechanisms, they use the respiratory burst, NADPH oxidase. The oxygen-independent mechanism, they use lysozymes and defensins. As a resolution, they apoptose after clearing infection, with macrophages cleaning up debris. You'll see increased neutrophils or neutrophilia in bacterial infections like pneumonia and abscesses, tissue necrosis, and also leukemoid reactions where there's reactive neutrophilia. There'll be a decreased neutrophils or neutropenia with bone marrow suppression like with chemotherapy, radiation, or aplastic anemia, severe infections like sepsis where neutrophils are consumed, immune disorders like lupus and Felty syndrome. Some disorders affecting neutrophils include leukocyte adhesion deficiency or LAD, which is impaired migration, chronic granulomatous disease or CGD, where defective oxidative burst occurs, and also in Chediak-Higashi syndrome where there's defective phagolysosome fusion. So step 1 is margination. So margination is the first step in neutrophil recruitment during acute inflammation. It involves the movement of neutrophils from the center of the blood to the periphery of vessels. So the first thing that happens is vasodilation slows blood flow in the postcapillary venules, leading to turbulence. In acute inflammation, this is triggered by tissue injury, infection, or immune activation. Vasodilation is induced by inflammatory mediators, primarily histamine and prostaglandins like PGE2, PGI2, and PGD2, and also bradykinin. The slower blood flow creates stasis, which allows neutrophils to interact with the endothelium or your blood vessels. Additionally, there's decreased shear stress allows neutrophils to migrate from the center to the vessel to the periphery. In normal laminar flow, red blood cells occupy the center, while smaller white blood cells like neutrophils are pushed towards the periphery. During inflammation, stasis allows neutrophils to move closer to the endothelial lining, a process known as margination. The clinical relevance of this: margination occurs predominantly in the postcapillary venules where blood flow is slowest and endothelial permeability is highest. Some conditions affecting margination would be a severe anemia or low red blood cell count. Neutrophils move to the periphery more easily. Also, polycythemia or high hematocrit. Increased RBC mass forces neutrophils away from the vessel wall. A high-yield chart I made, so the process of margination's mechanisms. Neutrophils move toward the vessel periphery due to stasis. The key mediators are histamine, PGE2, PGI2, and PGD2. Remember, PGE also produces fever, and PGI2 also inhibits coagulation. The clinical correlation, there will be decreased margination and polycythemia. The second step that occurs is called rolling. Selectins, or you can think of as speed bumps on the endothelial cells, slow down neutrophils. Selectins are adhesion molecules expressed on activated endothelial cells to initiate weak interactions with neutrophils. There are three different types of selectin. You have P-selectins, which are stored in the Weibel-Palade bodies, specifically endothelial storage granules. When you hear the word Weibel-Palade bodies, think P for P-selectin. E-selectins are induced by tumor necrosis factor alpha and IL-1, or inflammatory cytokines, and L-selectins are expressed on leukocytes, L for leukocytes, and help in later stages of leukocyte recruitment. Von Willebrand factor and P-selectins are both stored in Weibel-Palade bodies. So when you see Weibel-Palade, think W and P for selectins and W for von Willebrand factor. Von Willebrand factor is important for platelet adhesion, while P-selectin facilitates neutrophil rolling. Selectins bind Cia-Lewis X on neutrophils, promoting loose adhesion and rolling along the endothelium. Cia-Lewis X is a carbohydrate structure on neutrophils that binds P-selectins and E-selectins. This interaction creates transient bonds, leading to characteristic rolling motion along the vessel wall. In leukocyte adhesion deficiency, type 2, LAD2, defective Cia-Lewis X prevents neutrophils from interacting with selectins. Some symptoms that would be impaired rolling, which would be defective neutrophil recruitment, recurrent bacterial infections, poor wound healing, and severe periodontitis, or gum infections. For this process of rolling, the mediators are P-selectins, which are mediated by histamine and thrombin, and E-selectins with tumor necrosis factor alpha and IL-1. The function is to slow down neutrophils by weak binding to Cia-Lewis X. LAD2, defective Cia-Lewis X in LAD2 impairs rolling and recurrent infection. Step 3, adhesion. Adhesion is the third step in neutrophil recruitment, where neutrophils firmly attach to endothelial surfaces. This process is mediated by interactions between integrins on the neutrophils and cellular adhesion molecules, or CAMs, on endothelials. When I think of neutrophils, I think of integrity, so neutrophils have integrins. The first step that happens is cellular adhesion molecules, or CAMs, like ICAM1 and VCAM1, are upregulated on endothelial by TNF-alpha and IL-1. ICAM1 binds B2 integrins, CD11 and CD18 for firm adhesion. VCAM1 binds VLA4 integrins, more important for monocytes and lymphocytes. TNF-A and IL-1 are released by macrophages and endothelial cells, increasing CAM expressions. Integrins, CD11 and CD18, are neutrophils are upregulated by C5a and leukotriene B4, ensuring firm adhesion. Normally, integrins are in low affinity states but are activated by C5a, a complement component, and leukotriene B4, LTB4, a lipid mediator of inflammation. Once activated, integrins switch to a high affinity state, allowing for strong attachments to ICAM. CAM binds integrins, leading to firm attachment to vessel walls. This interaction stabilizes neutrophils on the endothelial surface, preventing them from being washed away by blood flow. Neutrophils are now prepared for transmigration. So in leukocyte adhesion deficiency type 1, prevents neutrophils from adhering to the endothelium. Some symptoms would be delayed separation from the umbilical cord, 30 days instead of 7 to 10 days, leukocytosis, high neutrophil count in blood due to impaired adhesion and migration, and recurrent bacterial infections, primarily mucosal and skin infections without pus formation. Remember, no pus equals lack of neutrophil infiltrates, because pus is basically dead neutrophils. So for adhesion, the mediators are ICAM1 and VCAM1, stimulated by tumor necrosis factor alpha and interleukin-1. CD11 and CD18 are integrins by C5a and LTB4. This allows for firm adhesion of neutrophils to endothelium. In LAD1, leukocyte adhesion deficiency 1, CD18 integrin deficiency, there's impaired adhesion, delayed umbilical cord separation, recurrent bacterial infections without pus. Step 4 is transmigration and chemotaxis. After neutrophils firmly adhere to the endothelium, they must exit the bloodstream and migrate toward the site of infection or injury. This process occurs in two distinct steps. First is transmigration or diapesis. Neutrophils pass through the endothelial barrier. The second step is chemotaxis, where neutrophils follow chemical gradient to reach the affected tissues. Look, chemotaxis. The chemicals are like their taxis. Transmigrate means they migrate through the vessels. So in transmigration or diaptesis, neutrophils squeeze between endothelial cells to enter the tissue. This occurs at the postcapillary venules, where the endothelium is more permeable. Once in the tissue, neutrophils continue migration toward the site of injury via chemotaxis. Neutrophils don't have eyes, they follow chemicals. Key chemical attractants include bacterial products like LPS or lipopolysaccharide, interleukin 8 secreted by macrophages, the strongest neutrophil attractant. When I think of interleukin 8, I think of interleukin date. The interleukin 8 is like a date for the neutrophils. It attracts the neutrophils. C5a is a complement component, recruits neutrophils and activates them. Leukotriene B4, a product of arachidonic acid metabolism, amplifies neutrophil recruitment. A high-yield clinical scenario would be Chediak-Higashi syndrome, an autosomal recessive mutation in the LYST gene or the LIST gene affecting microtubule-dependent vesicle trafficking. The consequence is defective phagosome-lysosome fusion impairs neutrophil function. The symptoms would be recurrent pyogenic infections like Staph aureus, neutropenia due to defective neutrophil movement, and giant granules in neutrophils due to impaired vesicle transportation. Also, hyper-IgE syndrome. Causes are the mutation in the STAT3 gene leading to impaired Th17 cell function and defective neutrophil recruitment. The consequence is impaired chemotaxis and immune response. So for this transmigration, the process, the mediators are PCAM1, and the function is the neutrophils exit the bloodstream at postcapillary venules. Transmigrate. They exit or migrate out of the bloodstream. Chemotaxis, like bacterial products, IL-8 or IL-date, as I like to call it, C5a, LTB4, this is where neutrophils follow gradient to site of injury. High yields are Chediak-Higashi, where there's a microtubule defect, and hyper-IgE or STAT3 mutations. Step 5 is phagocytosis. Phagocytosis is the process by which neutrophils engulf and digest pathogens or necrotic debris. This step is critical for bacterial clearance. So the first step is neutrophils recognize and bind pathogens or debris via receptor-mediated endocytosis. The key phagocytotic receptors are Fc receptors, which recognize the Fc portion of IgG, complement receptors that recognize C3b, opsonized pathogens, mannose receptor, recognizing microbial carbohydrate structures, and scavenger receptors that bind oxidized or apoptotic cell debris. The next step would be opsonins, IgG and C3b, which enhance phagocytosis. IgG is the most effective opsonin because neutrophils have very high affinity FCY receptors. C3b, a complement protein that binds microbes and facilitates neutrophil recruitment. Lastly, there's phagosome formation and fusion with lysosomes, or phagolysosome formation. Once pathogens are engulfed, they are enclosed with a phagosome. The phagosome fuses with the lysosome, forming a phagolysosome. Lysosomal enzymes then and reactive oxygen species kill pathogens. In Chediak-Higashi syndrome, the autosomal recessive defect that we talked about with the defect in the LIST gene, or the lysosomal trafficking regulator, there's impaired microtubule-dependent vesicle trafficking, which leads to defective phagosome-lysosome fusion. The symptoms would be neutropenia, recurrent pyogenic infections like Staph aureus and Streptococcus, giant granules in the leukocytes, albinism, and peripheral neuropathy. So for this, phagocytosis, mediators are IgG, C3b, or opsonins. Neutrophils ingest pathogens and necrotic debris. In Chediak-Higashi syndrome, there's a LIST defect, which is an impaired phagolysosome fusion, which results in recurrent infections, giant granules in leukocytes, albinism, and neuropathy. Step 6, there's destruction of phagocytosed material. So there's two different mechanisms. The first is the oxygen dependent, which is the most effective. This is where the oxidative or respiratory burst generates reactive oxygen species, ROS, to kill microbes. This occurs in the phagolysosomes using NADPH oxidase, superoxide dismutase, SOD, and myeloperoxidase, MPO. So the steps of the respiratory burst is NADPH oxidase converts oxygen to superoxide. Superoxide is highly reactive and initiates further reactions. Superoxide dismutase converts superoxide to hydrogen peroxide. Step 3, myeloperoxidase, MPO, converts hydrogen peroxide 2. Hypochlorous acid, or bleach. Bleach is the most potent microbial agent, rapidly killing bacteria. There's clinical correlations, for example, in chronic granulomatous disease, CG, NADPH oxidase deficiency, an X-linked recessive or autosomal recessive. The consequences is there's no superoxide production and defective microbial killing. Catalase-positive organisms degrade H2O, preventing alternative RS production. Common catalase-positive pathogens include Staph aureus, Aspergillus, Nocardia, and Pseudomonas sepsia. The other way is through oxygen-independent killing, which is less effective. This occurs via enzymes and neutrophil granules rather than ROS production. What happens is the enzymes are involved through the lysosome. A clinical correlation is with defective MPO or myeloperoxidase, leading to impaired hydrogen peroxide to bleach formation. The consequences are milder than chronic granulomatous disease. So for example, we now have these two different mechanisms. We have the oxygen-dependent killing, which uses NADPH oxidase, SOD, and MPO. Its function is to generate bleach via the oxidative burst. In chronic granulomatous disease, there's an NADPH oxidase deficiency, which means there's susceptibility to catalase-positive organisms. In the oxygen-independent killing, the mediators are lysosomes, and MBP uses enzymes rather than the ROS to degrade microbes, but in MPO deficiency, there's impaired candida killing. The last step is resolution. After successfully clearing the infection, neutrophils undergo apoptosis, allowing inflammation to resolve. Macrophages orchestrate resolution and tissue repair by secreting anti-inflammatory cytokines. So first, the neutrophils undergo apoptosis after clearing the infection. Neutrophils have a short lifespan, usually less than 24 hours in tissue, and self-destruct after pathogen clearance. Apoptosis prevents excessive inflammation and tissue damage. Also, there's pus formation. Pus is dead neutrophils. Pus, purulent exudate, consists of dead neutrophils, necrotic debris, and bacteria. Pus-producing infections include Staph aureus, strep pyogenes, and Neisseria gonorrhea. Macrophages also play a key role in resolution. Macrophages replace neutrophils as the dominant immune cell and have anti-inflammatory cytokines promoting healing and suppress further immune activation, like IL-10 suppresses pro-inflammatory cytokines, or transforming growth factor B, which stimulates tissue repair and fibrosis. So neutrophils undergo apoptosis. The function is prevents prolonged inflammation, and the clinical correlation would be excess neutrophils and chronic inflammation. The macrophage-mediated resolution is mediated by IL-10 and transforming growth factor beta, suppresses inflammation and promotes repair. Deficiency is persistent inflammation and delayed wound healing. So let's go ahead and jump into a few USMLE practice questions. I'll give you a few minutes and then we'll come back and review. Like I always will tell you, start with the last sentence, then read your answers, then read the entire question. I'll give you a few minutes and then we'll come back. So if you chose B, impaired neutrophil adhesion to the endothelium, that is correct. That's because this patient has leukocyte adhesion deficiency type 1, an autosomal recessive disorder caused by a CD18 B2 integrin defect, which prevents neutrophils from firmly adhering to the endothelium. Without proper adhesion, neutrophils remain in circulation, leukocytosis, and cannot exit the blood vessels to fight infections. Let's go on to the next question. I'll go ahead and give you a few minutes and then we'll come back and review. So if you chose B, that is correct. This patient has chronic granulomatous disease, an X-linked or autosomal recessive disorder caused by a defect in NADPH oxidase. This prevents the generation of ROS needed for microbial killing in neutrophils. As a result, CGD or chronic granulomatous disease patients are particularly susceptible to catalase-positive organisms like Staph aureus and Aspergillus. Last question, I'll go ahead and give you a few minutes and then we'll come back. So if you chose B, that is correct. That's because this patient has Chediak-Higashi syndrome, an autosomal recessive disorder caused by mutation in the LIS gene, which impairs microtubule-dependent trafficking for the lysosomes. This leads to defective phagosome-lysosome fusion, neurologic dysfunction, and partial oculocutaneous albinism. So that concludes our video for today. If you found this video helpful, please like and subscribe. Also check out thehealingpowerofnature.com and also our Patreon for the best study materials on the market. Thank you very much.